All right, we will get started for today. Welcome everyone for joining us on this webinar, Understanding Perinatal Mood and Anxiety Disorders. We're happy to have so many people able to jump on over the lunch hour. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota, which is a nonprofit organization established in 2022 with a mission to promote health and wellness across North Dakota by working at the community level. We continue to expand our statewide coalition to foster collaboration among local communities on common initiatives. By becoming a member of the coalition, you will be the first to receive information about educational opportunities like this one, legislative news, as well as access to digital advocacy resources and toolkits. Just a few housekeeping items to review. Webinar attendees will be automatically muted for the presentation because it is recorded. After the presentation, a link to the recording will be sent out along with an evaluation survey to complete. If you do have questions, please feel free to put them in the chat box and we will address them after the presentation. It's my pleasure to introduce our presenter today, Natalie Redder. I don't know if I said that exactly correct, but who is a licensed professional clinical counselor, licensed in both Minnesota and North Dakota with over 15 years of experience in the mental health field. In 2018, she founded Prairie Land Counseling Services, driven by her personal experience with perinatal mood and anxiety disorders, and a deep recognition of the need for more comprehensive reproductive mental health care in her community. Natalie holds certification in perinatal mental health and has specialized training in reproductive health through the American Society of Reproductive Medicine. A leader and advocate in her field, she was honored as the 2019 North Dakota Outstanding Mental Health Counselor in recognition of her contributions to reproductive mental health, clinical supervision, and her early adoption of telehealth before it was cool. In addition to her clinical work, Natalie serves as the current chair of the North Dakota chapter of Postpartum Support International, where she continues to promote awareness, education, and access to care for perinatal families across the region. So we are so thankful to have you with us today, Natalie, and I will turn it over to you to start your presentation.
Great, thank you so much. I'm going to share my screen here quick, make sure we got it all working out. Everybody can see it? We're good? Awesome,
Yes.
great. So thank you for that very lovely introduction, Mary. Like she said, my name is Natalie Reiter. I am currently located in Fargo, and I'm a licensed professional counselor. I'd like to start the presentation with kind of a little bit of a personal story. This black and white picture is a picture of my mom holding me when I was about 2 years old. My mom was 18 when I was born, and knowing what I know now, she actually had bipolar disorder, but didn't experience her first kind of manic episode until she was postpartum, which is very common for women who have bipolar disorder to not have episode or for to have their first episode in that postpartum or perinatal period. And then the current picture in color is me holding my daughter Ireland, who actually is 10 years old today. So it's a very special day. And she really is the reason that I kind of ventured into this field. This is Maternal Mental Health Week, and so you may be seeing a lot of maternal mental health information in your social media. And I think it really just is such an important topic to highlight. When I was pregnant with Ireland, we went through fertility treatments, which is a risk factor for PMADs. And I was lucky enough to conceive, and at about 6 months pregnant, went in for a regular checkup, and my doctor walked in and was like, "How are things going?" And I was like, just immediately started sobbing. It was just uncontrollable. And the response that I got was, "It's okay, we don't have to talk about it." And then the appointment went on. And luckily I had, a master's degree and, 5 or 6 years of counseling to know like, oh, maybe that's not exactly the response that we want. But it definitely launched my interest into the perinatal mental health field. So a couple fast facts. Actually, let me pause a second. I have a lot of slides. I have 77 of them. And I was emailing Mary this morning. She's like, "Are you really going to talk about all the slides?" I'm like, "No, I'm not. I'm probably going to skip." So you may see some skipping of slides, or you may see me talking about only certain highlights. But the idea is just to expose you to as much of the information as we can in this time period. So if you do see that I am not highlighting every point on every slide, that tends to be the reason why. So some fast facts about PMADs, or actually what we're currently transitioning to is PMHDs. Initially we always thought about this period of time as just postpartum depression. Oftentimes I will talk with women whose grandmothers were hospitalized after giving birth or institutionalized after giving birth. They come from these farm families where they don't talk about mental health, and they don't talk about, the impact of having multiple children over years, including losses. And so we've really worked on building from it just being postpartum depression, and then just postpartum depression and anxiety, to really understanding that all mental health disorders are present in this time period. But this time period has so many impacting and influencing factors: the life transition, the hormone transition, the role transition. All of these things are very special and unique about this period of time, which is why we really need well-informed community members and well-trained practitioners. So we have depression, anxiety, OCD, bipolar, and postpartum psychosis. A little bit of an asterisk here. Most of the data that we're going to be talking about is really based on cisgender heterosexual individuals. There is not as much in-depth research about other special populations and their responses to this kind of time period. So that is a research area that is definitely something that we can be looking into further. So this actually just came out last week, the maternal mental health fact sheet. So postpartum depression rates have increased from 2010, from 9.4% to 19% in 2021. So we're looking at a doubling in 11 years. And whether that's through more awareness, and recognition, or just the increase of, COVID, economy issues, all those things that have kind of been impacting how families function. But what we also noticed is that anxiety, obsessive compulsive, and bipolar disorders are actually increasing in diagnosis as well. And I always think, people tend to think that postpartum depression tends to be kind of like the main thing that we tend to see. Actually, I tend to see more of that postpartum anxiety, or that perinatal anxiety. So 20% of women actually experience an anxiety disorder, with the highest rates occurring during early pregnancy. OCD has a prevalence rate of about 8% in perinatal and 17% in postpartum period. And also, in women who do not have a pre-existing condition, so don't have a prior diagnosis of depression or anxiety, before the perinatal period, will experience bipolar at 2%. However, in women who have a pre-existing bipolar diagnosis, or have an undiagnosed bipolar condition, actually have at least one bipolar mood spectrum episode in the perinatal period. So 54% of them, which again is why we see a lot of women become diagnosed with bipolar disorder within this period, because their symptoms haven't been recognized, and we're just seeing some exacerbation of it because of the different factors. And so we often see some women coming out with a bipolar diagnosis. Leading cause of preventable maternal death. This is such a huge key piece. So according to the CDC, maternal mental health conditions, they identify this as suicide and overdose, are the leading cause of pregnancy-related death. So think about that. More than gestational diabetes, more than hypertension, more than preeclampsia, more than all of those things, suicide and overdose is the leading cause of death perinatally. But there's an asterisk there. And why is there an asterisk there? For a very important reason. The CDC does not identify homicide as a category in which they categorize these perinatal deaths. And why that's important is because homicide is actually the number one cause of death in the perinatal period. And 50% of those homicides are due to interpersonal violence. So we see, increases in interpersonal violence during the perinatal period, and this is a direct risk to a birthing person's safety. So of these mental health conditions, like the suicide and the overdose, 20% of maternal deaths are due to suicide. And I think this is fascinating. The cost of not treating mother baby. Oh, Mary, am I still on?
Yeah, it kind of froze for a second there.
Okay,
But
yeah, all of a sudden my power just flickered. And so I was like, oh no.
oh,
Okay, I think we're good.
okay.
Okay, so can you tell me what it froze on?
You were just talking about your that the let's see, kind of the last bullet point on
Okay,
that slide.
so the cost of not treating a mother baby pair, so both of them together, is $32,000 per pair. Not
I
like,
don't I don't think your screen is being shared right now though.
okay,
I think we gotta
okay, I'm so
I saw
sorry.
my face on your computer, so I figured I better.
Yes, no. Okay.
That's okay. There's always a technology
Well,
fluke
yeah,
here and there.
I'm so sorry about that.
Oh gosh,
Can
no
you see it
worries.
now?
Yes.
Okay. So, like we said, it's $32,000 per mom baby. So, not like as a whole, it's per mom baby, which means that it costs the US $14 billion a year to not treat these conditions. Like, think about what we could do with $14 billion in funding. Like, it's just kind of mind blowing. So, one of the things that we really want to talk about is detection and treatment. So, we know that these are concerns. So, what do we do with that knowledge? Well, that knowledge is really helpful. However, what we see, unfortunately, is that only 20% of women are screened. And so, I remember being given like a PHQ-9 or a GAD, and yet I'm not necessarily sure there was a whole lot done with it. But what we also know is that 80% of people are not being screened. And yet, we're screening every time we go in for a blood pressure check, every time that we go in for a temperature check, all these kinds of other things. These are just not things that we're seeing being incorporated into the treatment recommendations. And so this is an area of growth for everybody nationwide. So if you're untreated, if a mother comes in with a maternal mental health condition and she's untreated, we see increased risk of, like we said, interpersonal violence, preterm birth, less likely to get those routine medical care, and so the preventable deaths. They're more likely to abuse substances. Their time spent breastfeeding is shortened, and they oftentimes have more difficulty with breastfeeding. It does or can impact attachment to baby. Baby can have low birth weight. There's also the development of preeclampsia and gestational diabetes. But moms are not the only people who experience perinatal mental health disorders. 1 in 10 dads actually experience perinatal mental health disorders, and we believe it's the same in step parents and adoptive parents as well. And so what we know is that if the partner is left untreated, particularly with fathers, it can increase conflict in the home. There are building feelings of resentment towards baby. Oftentimes we'll see fathers engage in negative parenting patterns and harsher discipline. There's a decreased positive engagement. And this one, which I thought was just kind of like, what? Dads tend to adhere to safety guidelines less, like seatbelt usage and car seat usage. So there's like an increase in like risky or reckless behavior. So if a parent has a condition and is untreated, they are then at risk of some poor cognitive functioning, increased activation of fight or flight. They may have a harder time learning new things. They will also experience more fear. into stress situations, that stress response is increased, that activation is increased. Epigenetics, which genes are kind of turned on during development, that will also uh, can be a huge factor in what happens. Babies tend to cry more often and are harder to console. Again, that stress response is increased. They're more irritable and they're less curious because the world seems scarier. That stress response is increased. And so these are things that children are at risk of. Not that it's guaranteed to happen, but that they are just at risk of if we have a parent who is untreated. Who is at a higher risk? Again, I know these slides have a lot of data information. Um, so, we are trying to pass out as much information as we can. But who's at a higher risk? If you have a pre-existing diagnosis or you have a family history of a mental health concern, inadequate support and caring for a baby, financial stress, marital stress, pregnancy complications, major life events such as moving or a job loss, mothers of multiples, mothers of babies in NICU, thyroid imbalance, infertility treatments, any form of diabetes, mothers with a previous loss, and mothers who are veterans or in the armed forces. These are all people at higher risk of developing a PMAD. So, kind of getting into the conditions themselves, just very briefly, baby blues. This is just an experience by over 85% of birthing women. It starts the first week after delivery and it tends to peak 3 to 5 days post delivery and tends to resolve, though, within those 10 to 12 days postpartum. And it's most often associated with what we believe, like just like the hormone shifts that immediately happen in the postpartum period. And when we talk about hormone shifts, this to me is one of the most staggering facts ever. When you're pregnant, pregnancy oftentimes is sustained by progesterone. And so what is fascinating is that half of the progesterone that your body produces in pregnancy is eliminated from your body 38 minutes after giving birth. Just boom, half of it within half an hour. Like think about that. And we're wondering why, these weeks are difficult and why these things are being caused by hormonal shifts. And so then what we also know, though, about progesterone is this is where we're actually deriving a lot of the medication-based treatments like Zulresso and Zurzuvae. These are actually progesterone derivatives. Baby blues can look like things like dysphoric mood, excessive crying, crying for no reason, mood lability, anxiety, sleeplessness, loss of appetite, and irritability. Postpartum depression, 1 in 7 women experience it. Most often occurs in the first 3 months, but there are also a couple different periods that we really want to pay close attention to, particularly after weaning, because we see, again, hormone shifts, and when menstrual cycle resumes. These are also times when we can start to see PMAD symptoms exacerbate or to onset. Anxiety disorders. Generalized anxiety occurs in 6 to 8 months in the first 6 months after, or 68%, sorry, in the first 6 months after delivery. Panic disorder in 6 to 10 weeks, and social anxiety in early postpartum women. I want to talk about the anxiety disorder symptoms for a couple different reasons. One, I think people recognize that sometimes first-time parents can be kind of like overly anxious kind of off the bat, but this is when we're talking about kind of that excessive anxiety and worry. Oftentimes, this is also when we're going to see some of those what we call scary thoughts, so harm to self or baby, and they're generally linked to an anxiety disorder versus like an actual intent to harm self or baby. So when we talk about, assessing anxiety and we talk to women about the thoughts that they're having, oftentimes they're very hesitant or resistant to talking about these scary thoughts. And you have to have a pretty good relationship for them to start to open up about these things because it's a huge barrier to care. There's a strong fear of their child being taken away if they say, I was walking past the knives and I thought, oh, what if I accidentally stabbed my baby? Or what if I fall down the stairs and I crush my baby? And so they won't talk about it and they will minimize symptoms. And then we will see symptoms, increase rapidly. And so we really want to understand that, encouraging individuals to talk about what their thoughts are, but also understanding and informing them, well, this would be the actual time when we would consider, risk to baby or self to be of an imminent risk where we'd have to do some sort of kind of intervention along those lines. Like we talked about, bipolar disorder, 3% of pregnant women experience it. And research shows that 50% of women are first diagnosed in that postpartum period. Substance use disorders are often also present. They're co-occurring generally with another mental health disorder. And women are at higher risk for substance use disorders when their access to mental health treatment is limited. So a way that we, help treat and prevent substance use disorders in this population is by providing adequate mental health treatment. Postpartum psychosis. So this is rare. It's only present in 1 to 2 women per 1,000 births, not 100, 1,000 births. But this is generally the diagnosis that gets the most media attention. This is when we do see some suicide and infanticide because they are experiencing psychosis. Also, the onset of this is incredibly sudden. I mean, very quick. And it usually happens within those first couple weeks after delivering. Um, and again, a lot of it we think is hormone driven. So like if I'm seeing a client and that client is pregnant, I make sure that I see them within the first 10 days after giving birth, even if it is just for 10 minutes, just for me to have eyes on as a way to kind of step in and check and be like, hey, how's it going? How are you feeling? If you do, work with an individual who is actively experiencing like psychosis in this perinatal period, we need to get them to medical care for their safety and the safety of the babe. So again, this can look like delusions, hallucinations. Sleep is a big one. We already know that parents, especially new parents, their sleep can be kind of off, but these tend to be people who have very minimal sleep and also report not needing a lot of sleep. And so we really want to ask and assess about sleep. PTSD. So 1 in 3 birthing people report feeling traumatized by their birthing experience. So 33%, that's pretty high. Only 4 to 6 are diagnosed with PTSD, but we do hear really large numbers of people reporting experiencing trauma in their birth. And the thing about trauma is that it's not about what the actual experience is. It's about how the experience is perceived. When I started Prairieland, I met with a baker and he sat down and we were talking and he's like, oh, what do you do? And I was like, what, this is my population. He's like, I watched my wife give birth in that room and, they put the baby on her chest and she was happy and she just like looks back on it and reflects on it with such fond memories. But all I can remember is just watching her bleed and bleed and bleed. And I just didn't know how much blood she could lose before she was going to die. And so I think remembering that, PTSD and trauma is not about the event, it is about the experience. And there are multiple people in that birthing room, partner, birthing person, medical staff, and it's how they're experiencing the events. Also, very important to note that mistreatment during maternity care is much higher among Black, Hispanic, and multiracial women. And the maternal mortality outcomes are much worse, particularly for Black women. Body-based feeding and PMADs. So there is something called DMERS or dysphoric milk ejection reflex. And this is when a lactating person experiences a very strong, intense rush of negative emotions. It is a physiological feeling of irritability, rage, sadness, and this is generally experienced during letdown. Um, and again, they can experience it multiple times in a feeding because there are multiple letdowns. So feeding can be an excruciating experience sometimes. And it can last anywhere from 30 seconds to 2 minutes. And I've heard women talk about 5 to 10 minutes even. And again, we associate with a drop in dopamine. American Indian and Alaskan Native maternal mental health, kind of moving into some special populations. According to the Policy Center for Maternal Mental Health, American Indian and Alaskan Native experience higher rates at a rate of 14 to 30%. I think this is a very disturbing quote, but Indigenous women experience depression 80% more often than white women and experience maternal anxiety 37% more often than non-Indigenous women. And when we get into some of the data about North Dakota, a lot of our data in terms of disparities is with our American Indian population. Most pregnancy-related deaths of American Indian and Alaska Native people, 93% of the pregnancy-related deaths were determined to be preventable. If I were to give like a public health, foundation or just even a medical doctor or any sort of other group, and it's like you could prevent 93% of these people dying, it would feel like a no-brainer to work towards preventing these deaths, and yet we're seeing this year after year after year. Another really important thing is that researchers have often found that racism versus race is actually the factor that increases the risk for distress. So it is what a person is experiencing from oftentimes providers, and being heard or taken seriously versus the actual race of the individual coming in for treatment. Maternal mental health in the military. 28% of pregnant veterans and 40% of postpartum veterans experience a maternal mental health condition. So, average is nationwide 1 in 7. So we're looking at about 13%, but we're looking at 28% in pregnant and 40% postpartum. So again, we are seeing massively higher rates. And one study showed that 50% of mothers with deployed spouses experience postpartum depression. And a lot of times this is due to lack of community support. Paternal mental health. Like we said, 1 in 10 experience depression or anxiety. Men whose partners are in the perinatal period, this is actually a very sensitive time for men, as if their partner is in the perinatal period, they are twice as likely to experience depression than when their partner is not in the perinatal period. Peak onset is 3 to 6 months and oftentimes presents more as physical complaints, body pain, headaches, fatigue. They're going to talk about more physical symptoms versus identifying some more of like the softer symptoms of like thoughts or feelings. It can oftentimes also come across as anger or irritability, and stress is being identified as kind of the contributing factor. LGBTQIA2S plus populations, understanding that 35.6% of sexual minority women screen positive for perinatal depression. So again, if we think about 13% is like the average population, 35.6 in this specific population. And remembering that lesbian, gay, and bisexual adults are twice as likely to experience a mental health condition, and transgender adults are 4 times more likely to experience a mental health condition than their heterosexual peers. They also have a higher likelihood of attempting suicide. Like I kind of referenced earlier, according to the CDC, almost half of homicides to women who are pregnant or postpartum have been found to involve intimate partner violence. Pregnancy is an especially dangerous time for people in abusive relationships. Abuse can often begin or will escalate during the pregnancy. So, Lebu Jackson and Raina did a latent class analysis on identifying what were some social determinants that contributed to the development of PMADs. And what they found was that the top four are intimate partner violence, housing instability, history of substance use, and low social support. Talking about again about racism, women of color are 3 to 4 times more likely to experience complications and die from these complications. And institutional racism, particularly in healthcare settings, contributes to Black women receiving lower quality of care, um, such as giving birth in lower quality hospitals, and then being subject to dangerous, demeaning, or humiliating treatment. I think one of probably the most kind of like well-known examples is Serena Williams, had to advocate multiple times with her doctors that she was experiencing blood clots in pregnancy and, was not believed and not believed until she was in an emergency, a medical emergency. And then finally they were listening to her and kind of, assessing what she was telling them what her body was doing. March of Dimes. March of Dimes comes out with a report card every year. And this report card goes over things like rates of preterm birth, rates of C-sections, where hospitals are found. And so if you ever have a chance and haven't looked, looking at the March of Dimes report card is really, really fascinating. One of the things that they look at are where are the maternal health deserts? So, a maternal health desert means lack of care within 20 minutes. So, if we look at North Dakota, which is outlined in yellow, we really only have full access to care um, in 8 counties, and one has a moderate access to care. And again, if we look at where these counties are located, it's Williston, Minot, Grand Forks, Devils Lake, Fargo, Jamestown, Bismarck, Dickinson. So if we pair that, I want you guys to think about this map with this next map, which is the mental health deserts. So this is where, there's a shortage of mental health providers. We then reduce significantly. Williston doesn't have enough. Dickinson doesn't have enough. We're looking at Minot, Bismarck, Mandan, and then the Fargo Grand Forks corridor. So Blue Cross and Blue Shield sent a report out last month. They call it North Dakota Close Up, focusing on maternal health. And so what they identified were the disparities in accessing prenatal care really comes in terms of teenage pregnancies and pregnancies involving American Indian, Black, and Hispanic individuals, birthing people who are not married, uninsured, or have less education. This is where we're seeing the disparities in accessing prenatal care. So there is a screening or assessment called the ACEs, or Adversive Childhood Experience Scale, and it came out of a huge study that Kaiser Permanente did. And what they found was that people with chronic health conditions oftentimes had these similar childhood experiences. So we have a list of the ACEs over here on the right: emotional abuse, physical, sexual abuse and neglect, incarcerated household member, divorce, things along those lines. And so what they found was that in 2021, 29% of mothers who gave birth had a score of 3 or more. And we know that with an ACEs score of 4 to 5, the likelihood that they will experience a chronic health condition goes up by like 50%. And with a score of 6 or more, that their lifespan decreases by 20 years. So 30% of mothers already have a score of 3. And the populations that are more likely to have a 3 are younger mothers, unmarried, American Indian or Hispanic, and less education. And these populations are also more likely to experience unintended pregnancy, depression, and physical abuse. So I think we're kind of starting to see these themes of, interpersonal violence, lack of access to care, um, leading to where we're seeing these rise in PMADs. In 2021, 13% of North Dakota birthing mothers had postpartum depression. And again, it was most prevalent among women who were younger, less educated, lower household income, unmarried, and American Indian. A maternal mortality rate looked at, um, so a study presented at the Society for Maternal Fetal Medicine looked at CDC data from 2005 to 2022 and looked at the cause of death for people who were pregnant. And Black birthing people ages 18 to 24 experienced death due to homicide at a rate of almost 8 deaths per 100,000. And that is nearly 4 times the national average. We did see a slight decrease in maternal mortality for 2023 from 2021 to 18.6 deaths. But again, in 2023, the maternal mortality rate for Black women was 50.3 deaths, while for white women, it was 14.5, and Hispanic women is 12.4, and Asian women was 10.7. And the CDC did not have information on Indigenous women, but North Dakota's maternal mortality committee review does. So according to the North Dakota Committee on Maternal Mortality, what we're seeing leading causes of death, pregnancy-related death, again, mental health conditions, hemorrhaging, cardiac and coronary conditions, thrombotic embolism, cardiomyopathy, and hypertensive disorders. So these are how we're seeing, birthing people and their mortality rates in North Dakota specifically. The disparity are, according to our maternal mortality committee, American Indian and Alaska Native maternal mortality ratio is 29.7. And all minority populations incur significantly higher maternal mortality rates in North Dakota. So 7.7 to 12% of births in North Dakota are to American Indian mothers, and 80% are to non-Hispanic white mothers, and yet 93% of pregnancy-related deaths for American Indian women are identified to be preventable versus 80% of Caucasian deaths. And rurality is a big factor here. Barriers to care. So what is impeding individuals' ability to access care? Huge one is actually knowing what a perinatal mood or anxiety disorder is. A lot of times they'll go in, if they talk to somebody, it is minimized or just like, oh, it's just a part of pregnancy, or that's just normal, cost of travel, childcare, which we already know North Dakota has a huge deficit in childcare opportunities. Again, healthcare providers normalizing. Like I talked about earlier, unclear about like if they talk about this, is their child going to be taken away from them? That is a huge fear and a huge barrier to care. A lack of network to help postpartum patients, a lot of difficulty navigating the system. So in North Dakota, there are 18 mental health counselors who are certified in perinatal mental health. That's it. 2 of them are me and my coworker, and I have a third one who's getting certified this year. But if we think about to cover the entire state, it's in such an incredibly low number. So how do we help? What do we do to help individuals who are birthing? Doulas. Doulas are great. We love doulas. Doula guidance increased positive delivery outcomes. They reduce anxiety and stress. And doula support, specifically in low-income women, was shown to improve breastfeeding success. And so, they're connecting individuals with doulas can be an incredibly important step in order for them to feel empowered in their birth experience. Body-based feeding. We do know that breastfeeding or body-based feeding does contribute positive hormonal changes in our mood. It releases oxytocin. It can reduce some progesterone. And so it's really a great thing if we can kind of encourage Fed is best, obviously, but if this is a person's desire is to body feed, how we can support them the best way possible, because it does have a protective factor built in. Treatments. There are medications I talked about. There's azolone and brolaxolone. Sorry. We talked about therapy, social support. Social support is the biggest one. And that's kind of where we get into where PSI, I'm skipping over this screening, is where PSI, so Postpartum Support International, is a national organization that works to empower parents and birthing individuals to get the support that they need to address their mental health. The website is excellent. It's postpartum.net, has a lot of resources both for training for professionals and frontline workers. They also have a helpline. So you can text help in English or in Spanish or call, and somebody will respond within 24 hours. They also can call the helpline and get connected to mental health providers. And generally, this person, who is a volunteer, um, will connect and send out a call like, hey, does anybody accept this insurance and have openings, within the next couple weeks? And people will respond back. I have an opening, I accept that insurance. So we can connect people with the kind of help that they're looking for and that they need. If you ever want to look up the directory yourself, the directory is just psidirectory.com. But one of the best things about PSI is the support groups. They have over 35 free support groups based on a wide variety of specialized needs. NICU moms, moms with ADHD, parents, Hispanic, birthing parents, who are not parenting, but they were just the birthing individual, bipolar psychosis, you name it, they generally have a support group for it. And these are free support groups that they can access that will connect them with trained individuals. They also have a peer mentor program where parents who are in need of support are paired with a trained volunteer to help with recovery. We know peer support is extremely beneficial in recovery for a variety of conditions, and this is one of the services that PSI offers. Chat with an expert. So every Monday, they can talk with a mental health expert. Generally, dads is for Mondays and Wednesdays is for moms, about resources, symptoms, treatment options. Kind of a drop in, ask our questions, find out. Also, they are on Smart Patients Forum. They have a special forum on the Smart Patients platform. And they have social media and a discussion tool that they utilize so that you can go in and ask your provider questions to get your own needs met. They also, this is a really great one. And so whether you prescribe or you know people who prescribe or you are going to somebody who prescribes medication, they have a psychiatric consult line. So a medical professional who prescribes can call and talk to another medical professional who prescribes and get information about, this is what my patient is presenting with, what are my treatment options. And so they can specifically talk with people who may have a little bit more experience or expert, just a different opinion. They have trainings and annual conferences. And again, they provide a lot of that frontline training. They also have the Perinatal Mental Health Alliance for people of color, and you can be a member of PSI, and including the state chapter. And if you're ever interested in getting involved with the state chapter, you can just go to psichapters.com/ND for North Dakota, and it has all of our information. And it also has our contact form. And if you have ever interest in being a volunteer or being on the board, let us know. Our board is very new. We just started in 2023, and so we're really kind of working on building what a good functioning board looks like. We've been present at a couple different tabling events. We've done some speaking engagements like this, but we're really looking forward to launching in 2026 and doing some more boots on the ground work. So if you're ever interested in volunteering or being on the board, we are very, very interested in having you come and work with us. Other just really wonderful basic resources that everybody needs to know about: 988, National Suicide Prevention Hotline. Um, the crisis text hotline, this is actually separate from the National Suicide Hotline, and they can help you with just emergency resources. There's been a tornado, there's been an earthquake, I'm having suicidal thoughts, I need food, housing or food resources. If you text home to 741-741, it will connect you with an expert. The domestic violence hotline, because again, we know interpersonal violence can be kind of high during this time, text START to 88788. And there is a specific hotline just for maternal mental health. And that is 1-800-852-6262. And it spells 1-800-852-MAMA. So providers, there is a certification, which you can look on the website. And it is for both, or for individuals doing therapy, psychopharmacology, and affiliated professions: peer support, lactation, doula, physical therapist, pelvic floor, things kind of like along those lines. So I know we're kind of at time, and so I want to, pause and give some time for questions. I do want to say thank you very much for having me today. I know I talked about a lot of things, and provided a lot of information. And so I'm really open for questions right now.
Wonderful. I think I'll just quick pop my slides up
Yes, oh, I will stop sharing.
and let me see here. We can move to questions. All right. I think it's showing. It was a little weird on my computer, but all right. Yeah, we do have one question. Will the slides be shared? The slides, as of right now, I think we talked about just sending the recording out, so the slides will be in the recording. And then any additional resources will be linked in the email.
Mm-hmm.
And so we did have some questions that came in during registration. I know you covered some of them, but just in case, just to highlight them, I will just kind of
Yeah.
run through them, if that's okay. So one question was, what suggestions to bridge the gap between hospital stay postpartum to clinic visits and supporting postpartum women?
That is a great question because, we didn't go over screening recommendations, but, screening recommendations are, 1 week, 2 week, 4 week, 6 week, 10 week, and then every 30 days after a positive screen. And so we know that, women oftentimes don't go and see a medical provider for themselves until that 6 weeks appointment. And so there's been a lot of, encouragement to have pediatric screenings. But for how do we bridge that gap between them and clinic visits, this is really where our community support comes in, making sure that like occupational physical therapy individuals are educated, lactation consultants are educated, any sort of program that works with new families or families that have just recently given birth have education opportunities, because these are the people that they're going to run into or have more frequent interactions than that one time 6 week checkup, or even just the baby well checks. So those things are incredibly important and helpful in trying to identify like who are the people who interact with our community members most. Whether it is even like being involved in the church and having people drop off meals who are coming into contact. The more awareness about this, the more that they're going to have contacts with communities who are going to be able to be there and support and help.
Thank you for that. And one just came in the chat. Are there specific treatment models that have shown to be effective for postpartum mental health disorders?
Yeah. So gold line is CBT. Tends to be, or cognitive behavioral therapy, tends to be extremely helpful. Actually, just community support and engagement tends to be incredibly helpful. We also want to work on sleep hygiene as being very key, and a treatment model, which I know is not like specific treatment in terms of a model, but we see CBT. I do a lot of CBT ACT, a lot of EMDR, to help some of the trauma. But CBT tends to be the treatment model that is most often cited.
Great. And then next, Jennifer asked, how do you help women understand the importance of staying on their meds during pregnancy when they are fearful of side effects on baby or starting meds for perinatal anxiety?
That is a great question. So there's a wonderful website called Mother to Baby. And this is actually a website out of Australia. If you want to know where the cutting edge information and research is coming out of for birthing individuals, it's Australia. They have it down, but you can type in almost like any kind of substance and it will give you a transfer sheet. Like what is transfer during, how does it how does this, medication or like things even from like Zyrtec or Benadryl, impact conception? How does it impact during pregnancy? How does it cross in terms of breastfeeding and milk supply? And it will cover those things. The other, so like talking with women, having them access and have data that they're like, okay, this is maybe what it looks like. And then talking to their medical professionals and being like, if I'm on Zoloft I'm pregnant now, can I stay on it? Is it safe? And when it comes to medications, oftentimes we look at, risk, which is riskier for a woman to experience high levels of stress throughout the pregnancy, or for a woman to, have a medication where there are potential side effects of like some withdrawal, usually seen within baby in the first, even like lithium, women can be on lithium as long as we are frequently testing and making sure that, levels are within that therapeutic and safe range. ADHD medications, a lot of women will go off of them, which is totally fine. But for some people, it is just not beneficial to be off of an ADHD medication. So they talk to their provider and they try to get a game plan kind of worked out. And again, I think it's empowering women to understand what their options are so that they can go to their medical providers and have full discussions about how does this, you know, impact me directly? How is this going to impact my situation? Because my situation is unique to me. And this pregnancy is unique to me. Not even just, I had two pregnancies and they were each different. So, one I took Zoloft during, one I didn't. And I can tell you that the one I took Zoloft during was much better, much more enjoyed than the one I didn't. But, both of my children came from the same mother and, all those things, but we're completely different experiences in terms of pregnancy. So really understanding that all of that is unique and having a healthcare provider that will listen to you and that you can talk to and ask questions and give the, consult line if they want to consult about it is very helpful.
So thank you for sharing your experience as well. I think that's helpful for everyone. Um, and then can you talk a bit about the time period associated with postpartum, since there are differing definitions?
Yes. So, okay, just give me a second. So postpartum, we consider in terms of like a clinical diagnosis to be post birth to the year after birth. Um, and so, like, if somebody's coming in and they're within that year, that is when we would identify it as postpartum. There are some studies that suggest, like, I read one study that talked about that the sleep deprivation that you experience in the first year of having a child, you don't get caught up until they're like 5 or 6. And that is just if you, and then obviously if you don't have subsequent children, then it takes kind of even longer because you're kind of deeper in that sleep debt. But there has been discussion about it being to 2 months or 2 years. Some want to talk about 6 months. But in terms of the clinical standard, we identify postpartum as, data giving birth to a year after.
All right. And then I don't know if I know what
Oh,
she,
mother to baby. The website is
oh,
called Mother to Baby.
oh, sorry. Oh, yep, mother to baby. And I will try and get that sent out in the follow-up email too, so
Yes.
everyone can have that resource. Okay. Let's see. I know you touched on this, but would you just kind of repeat or go over the specific disparities that exist for the PMADs, especially in the populations in North Dakota?
Yes. So we see the disparities are really present in, you know, indigenous population, in those who are have less than a college education, those who experience financial stress, teenage mothers, and lack of community support.
And then we had, and you definitely probably covered this, ways to help or resources to give when moms say that they're experiencing depression. And so I know
Mhm.
you've given some examples and information, but is there anything else you might want to add?
Again, like I think we cannot underemphasize the need for connection during this period. I had one of my staff who's going to take their certification test this year just went to a training last week that PSI put on, and one of the things that they really focused on was COVID and how women who were pregnant during COVID or gave birth during COVID have a lot of kind of residual trauma, and now these kiddos are going to be entering kindergarten this year. And so it'll be interesting to see kind of what sort of things are kind of coming out of that. But you know, prior to World War II, most families were multi generational, whether it was on a farm or in a city. And we saw these individuals or groups of people living together so that support was is innate and it just naturally involved. And there are communities around the world that have periods that they call laying in, where like the first month or two after giving birth, the mom doesn't leave the bed or doesn't leave their house, or the community comes in and helps feed and watch and care for the mom and the baby pair. And this is something that has been around for thousands of years, yet we're really disjointed and disconnected from our communities. And that's why it is so important, why we cannot, you know, underemphasize enough the fact that we need to support individuals, birthing individuals as a community.
Yes. Thank you for that. And one more, what challenges would a baby face in their future if they were separated from their mother at a young age?
So that is really going to depend on, does that mean that they're going and staying with individuals who are, all like parent alternatives, like in terms of like an adoption or something like that. We saw a lot of really interesting information come out of studies of, babies in orphanages, particularly in Eastern Europe, like the Soviet Union, who were not attended to, kind of coming out with some like that reactive attachment, and some difficulty in creating connection. But the thing is that there is a great resiliency in children, just phenomenal resiliency in children. And so as long as the child there feels safe, has their basic needs met, and feels loved, these are the things that are going to be the most important for their success. They are cared for, their needs are met, and there's physical safety. And so if this child, like 5 months is placed in another household or with other individuals who are providing that, then we're not going to see huge disparities, in terms of developmental milestones or developmental or just development. But if they are taken, from a parent and then placed with individuals who are not providing that, that's when we're really going to see a lot of discrepancy.
Well, thank you. I don't see any other questions that have come in. Really appreciate you, Natalie, being here today and presenting on such an important topic. And it really was a perfect month to lift up this topic as it is Mental Health Awareness Month. And so I will kind of move to our closing slide since we are almost at time. Again, thank you. And to all who could attend, we will be sending out the recording along with the resources that so everyone can review those. To stay connected with us, you can follow Healthy Nodak on Facebook, Instagram, Twitter, and Foundation for Healthy North Dakota on LinkedIn. And also to join the coalition, you can visit the link and stay aware of future webinars and updates on the foundation. And here's another opportunity to scan the evaluation QR code, but it will also be sent out in the follow-up email. So appreciate just everyone's time today. So thank you and enjoy this beautiful sunny day in North Dakota if you're in this state. Wonderful. All right. Have a good day, everyone.